Wonderful. Well, if folks are ready, we can go ahead and get started. Welcome to this Rural Network Response Team presentation on emerging dental innovations and technology. I'm Annalise Cothran. I am a Rural Network Response Team member, and I'm very excited to be able to facilitate this discussion today and hear from each of you about this topic after we hear about from Dr. Boynes about this about the initiatives under this topic. I'm sorry, I got a bunch of stuff over here on the side and it distracted me for a moment. I apologize. So first, I'd like to ground us in this purpose for rural NRT. And again, this is really facilitated by Joni. So first and foremost, I want to give Joni Nelson a shout out. She's done a wonderful job facilitating this and really creating a robust NRT on behalf of Open. And so while this group is sort of here providing context and support for these purposes, I do want to specifically give a shout out to Joni and her leadership and helping us stay grounded in these purposes and activating us in this way. So these are our three purposes, and they're kind of put together throughout the year, and the NRT moves forward with activation and engagement under these three key areas on policy, highlighting strategies around oral health in rural communities, and then promoting data collection efforts. A little bit of housekeeping before we begin. Everyone has been muted, so please keep yourself muted until we're ready to engage in discussion. So for the first part of this, we'll have a presentation by Dr. Sean Boynes, and then afterwards, we'd love for everybody to engage in discussion. Feel free to type any questions that you have into the chat box. Joni and I will be available, as will Dr. Boynes, in the end of this discussion. And so we'd love to be able to hear any topics or ideas that bubble up throughout. And then, as you know, this virtual roundtable is being recorded, and so it will be posted to open communities after. So as a bit of a welcome, we would love to know who is with us. If you are able, type in your name, your organization, the state that you're from, and maybe a fun fact about yourself if you're excited, maybe something you're excited about for next week for Thanksgiving. I'm personally excited about food, and I really like macaroni and cheese. So anything else that you want to add as a fun fact about yourself? So while we're hearing that, seeing that in the chat box, I'll also just review our agenda, which is we will start with a presentation, and then we will move into a virtual discussion where Dr. Boynes will kind of lead this discussion, but we also, again, as I mentioned, want to hear from each of you on these topics, and then we'll wrap up just before 12. So without further ado, I'd like to introduce Dr. Sean Boynes, who is the president of Dental Medicine Consulting. Sean, I'm going to hand it over to you.
Thanks, Dr. Cothran and Dr. Nelson. Kudos to both of you for all the work that you're doing in the rural space. I do not have blue hair anymore, much to the chagrin of me and many others. But who knows, maybe it'll make a comeback one day. But do like the fact that this was the picture that we have up. I've been an advocate for rural oral health for quite some time. I think most of my knowledge and experience and what has shaped a lot of decision making was when I went to South Carolina, and our first fixed site was in a double wide trailer in the middle of a cotton field. And that's not figurative. That is really where it was at. And the first office I had at my FQHC was really in the middle of a cotton field. So very happy to be able to have this discussion with you all today. Next slide. So really, my plan is to sort of talk about where disruption is coming for data and technology, how it can be used effectively within the rural environment, but also some of the warnings that come along with it. Next slide. So I thought I would start here, which is kind of where things are going. And when you look at this wonderful analysis that was done by Roland Berger, which is a consulting think tank, they went out and talked to 500 of the biggest of the bigwigs in the tech sector, both in health and in other areas. And they really tried to set out to understand who is going to own the patient. And it's in quotation marks, and it really means who's going to own the patient data along with the patient. And what they really found out was that for healthy individuals in prevention, the big tech players are going to have a lot more opportunity and say in what prevention processes will move forward. And if you think about it, it's because they already have a lot of the data that can impact that. If you go to Amazon, they know what you buy. Your phones know what you buy. They know what you eat. They know where you go. They have all of those systems in place that can give them the information that can help really move an individual to understand what their health outcomes may be. And you can think about a future where you have somebody who might be 23 and all of the information of what they do, how they do it, gets put into this data center. And they can project out and say, well, if you keep going down this path, when you're 55, here is your projected outcomes. And it's very similar if you think about a Fitbit. If you take this many steps, we would expect this much this many calories to be taken off. If you do this, we would expect you to have better sleep. Whatever it may be, we're kind of already moving into sort of that structure. They also found out that when individuals do develop a chronic disease or they need more attention in their care, they're more likely to want to move their data over into a siloed protected structure, that they tend to not trust the big tech players as much with that health information. And so the healthcare provider, whether it's inpatient or outpatient, will most likely own most of the data for patients with health problems. Next slide. So here's a great piece of tea leaves. So if you didn't really believe Roland Berger's work, here's McKinsey and Company. And this is one of those ones I'll recommend if you do have time to read something in the next couple of weeks. This is a quick read. The link is below. Give it a read because it really defines out where the future of tech and data are going because of the influence of big tech like Apple, Microsoft, Android, Amazon, AWS, which is part of Amazon structure, Google, and Microsoft. And you can see they're right now investing in a lot of layers of engagement, searches, wearables, e-commerce, behavioral health apps. They're investing in layers of infrastructure on the bottom, which is kind of data capture. If you think about AWS, which is Amazon's cloud-based service, you can see that they have a lot of medical information already. And so the idea will be that they'll develop a layer of intelligence that we talked about that could predict how health is going to move forward. I think from a rural standpoint, it becomes an interesting structure within the care delivery system, because if individuals are not in areas where there's broadband or areas don't have the capabilities to plug into their own data for health, then what is the responsibility of the care delivery centers and being able to help a patient with their data in the rural environment? Does that become responsibility of these care delivery centers as individuals come in for their healthcare? And I think we're still struggling to determine how that will move forward, especially since we're still at about 25 to 28% of our land mass here in the US without any type of broadband or what we would call high-speed connections. Next slide. So this is the future of integration, which is virtual experiencing. This is from that McKinsey and Company analysis. And really it demonstrates how advanced analytics are being put into health plan platforms and apps. And I like to tell this story about my mom's care. And I do have permission to break HIPAA in any way, shape, or form from my mom. But I do help her with her care. And she was going in to have a procedure done, and we needed to get some blood work accomplished. And unfortunately, she takes biotin, which if you take biotin, it's hard to get a thyroid level, hard to get your A1C levels. So she had to go back home. She lives in a rural area. And so there's a local place where she can get it. And she does have the app. I have it on my phone, her app for her health system. And I was told by her provider that I was going to get the results of the test a couple of days before she would. And if I could screenshot it and send it to her, that they would be able to get my mom in the next day. And sure enough, we go, she gets blood work, they put it in the system. I have it, I think, within 15 minutes with an artificial intelligence explanation, like the computer explaining what is there. I did the screenshot and they got right back in. And so we're seeing this advancement. What the proposal is in front of you is what happens if we can get social structure data from the zip code? What is your local environment? How healthy are those folks? Things like transportation services, faith institutions, community, family, and state assistance numbers. Those all factor into sort of a health outcome. What if that can get factored in with the things we're used to, like provider generated data, financial data? And then we can start to get patient generated data, home health monitoring, or doing teledentistry, telehealth, virtual care, and getting counseling data out of that. And then we mix that in with daily life activities like your Fitbit. And all of those come together to paint a pretty significant health picture. It would allow a patient to understand where their health is at, how the system is treating their health, and where their outcomes are compared to other people who may be similar. And so it'll be really interesting as we move forward to see how these kind of health plan platforms, these apps that are on phones, how that's going to positively or negatively affect the overall process of health and healthcare. Next slide. So we talked a little bit about teledentistry and that other structure. So this is sort of a potpourri lecture. So this is one of my hard transitions into a new topic. But if you remember on the slide I just showed you, telehealth and virtual care can become a point of input for data. And I think what has happened in Pennsylvania recently is a desire to sort of understand how we can utilize teledentistry better for a population. So this is a bill that passed. This is 1729. I'm from Pittsburgh, Pennsylvania. That's where I live now. And so this particular bill I followed all the way through. It took about 2.5 years to get it finalized and to get the reimbursement structures in place. What was able to be accomplished here is that for teledentistry, you can bill the procedures you see, a limited oral evaluation. You're allowed to send individuals topical fluoride varnish and instruct them, and you can bill for that fluoride application. And you're allowed to have tobacco counseling and nutritional counseling, as you can see in the codes that are over 1, 2, 3, 4 columns from your left to right. And really, it was that tobacco counseling piece that really allowed a stronger lever to get teledentistry moved forward, because the idea is Pennsylvania, like many states, are having a lot of vaping issues, especially in the rural environment. And so being able to offer this type of counseling as an additional visit became a pretty easy thing to get passed in a bipartisan way. And then to be able to get the fact that this can be delegated, like to a hygienist, you can see when you look at the reimbursement rates, pretty effective. If you can do one of these visits in a 10 to 15 minute span, you could produce good revenue in an hour, and it does develop a financially viable and sustainable structure. And so really, I think this was interesting because of the tobacco counseling, because of the nutritional counseling that can be inserted in, and that you're having this additional almost primary care sort of visit. And you could think about the implications here. And so I wanted to specifically share this bill and give you the hint that when you have the tobacco counseling in there and you can point to a vaping issue in the state, it's pretty hard to be against something like this overall. Now we'll see what utilization is. Right now, you would expect to have more utilization than we're seeing. However, we are seeing good utilization in the rural areas. And this is almost becoming sort of an augmented structure for rural providers, especially when they're able to have more outreach and expand the mileage and the radius of their care delivery structure and business. Next slide. Just wanted to share this because there are still some concerns to move teledentistry forward. And I know we're looking at that as a good structure to have in place to help with rural environments. We're still having dentists feel very concerned about gaining patient consent for the teleconsultation, and then confidentiality, making sure that there's no breach that could occur, and that whatever medium is being utilized is a safe structure that wouldn't lead to some sort of liability or a HIPAA violation or something of that nature. There's still concerns around digital forgery, but that's mostly related to prescriptions and things like that. That they can say they had a telehealth visit and go in and forge some sort of prescription using the telehealth visit as a structure to do that. And little less concerning with incompatible hardware and software, and then reliability of teledental equipment. Although that does come up, especially in some of the recent presentation and CE courses that I've delivered when I ask, there's still things where it will, you could be on a call and then the call ends, or somebody else's Wi-Fi isn't working as effectively and every other word is cut out. And you have a whole lineup of patients you're seeing for telehealth that day. So we still have to get a little bit more reliable in that structure. Next slide. Another transition, thinking about how we can start to utilize technology, utilize mediums like teledentistry, is the fact we understand the microbiome at levels that we've not seen ever. And we can start to understand what specific bacteria are causing what specific issues. And in the picture on the left-hand side, you can see that the bacteria is spreading through the gum tissue, getting into the blood vessels. From there, they cause an inflammatory effect. Over on the right-hand side, you can see all of the mouth bacteria that are associated with poor outcomes of health and what organs or what disorders they're associated with. I always like to point out the biggest bad guy is the Porphyromonas gingivalis. It's associated with periodontal disease, primary cause bacteria of that, but also all of these other agents. You can find how often it appears within the structures of bad outcomes. Next slide. Because we're getting better knowledge in what type of bacteria are present and what diseases or outcomes they may cause, it's really heightening the ability of salivary diagnostics. This particular organization, they have some unique things that they're actually looking at risk stratification. So identifying risk, which is what you see in that how do you stack up. You see this individual is a 5.4. Healthy people within this system that have their microbiome salivary diagnostics tested 1.3, and people with this particular tooth decay disease, they're usually at an 8.3 rating when you look at percentages of bad bacteria. Over on the right-hand top side, they can show you exactly what bacteria that you have. And then at the bottom, they have artificial intelligence that allows for recommendations on treatment and what type of agent may be best based on your bacteria. It might not always be the traditional fluoride dentifrice or fluoride toothpaste. Maybe you need an arginine toothpaste with the microbiome you have. Maybe you would benefit from a probiotic or chewing a probiotic to help make sure that your microbiome is in good existence with each other. The truth is we need that bacteria. I always say there's not good and bad bacteria. It's all there and it's all needed, right? We need them to eat the carbohydrates that come in the mouth. We need the carbohydrates to live. Could we use less sugars? Yes. But I'll point out that you get just as much acidic events from things like pasta as well. So we have bacteria that start that digestive process. You always see bacteria with like a frowny face as a cartoon. I think it should be a happy face because they're doing the job that we need them to do. The idea is that we want the right amounts. So your microbiome needs to be a little bit country and a little bit rock and roll in order for it to exist. And we're getting to the point now where we can use salivary diagnostics to effectively treat the microbiome overall. And this can be done from anywhere at home, truthfully. Next slide. We're getting earlier detection. So now we can kind of find out what your mouth is made of and all those microorganisms that cause the bad structures to happen, like inflammatory mediators. So those inflammatory mediators that bacteria causes to that produces negative outcomes. And so the worse a cavity gets, the worse your gum disease gets, the more of that bacteria that you have that's categorized as bad proliferates and causes more systemic outcomes and systemic disease. So now we're getting to the point where we can start, through artificial intelligence and predictive imaging, start to find earlier lesions or earlier bone loss than any other time before. And so this is just a picture, an example of this type of system that is going in and finding these lesions that are earlier. Highest accuracy in these evaluations were 99%, lowest was 73%, and it can assist dentists and radiologists to perform a better and faster examination, but also should allow for us, next slide, to be able to start to use new materials. So we're getting to the point not only where we have the ability to look at the microbiome, find these things earlier, but now we can find these new materials that are out there that give us the in-betweens that we've never had before. You don't have to wait for a cavity to form. You can treat it beforehand with remineralization agents. You no longer have to send somebody directly to have an extraction because Medicaid doesn't cover the root canal. You can start to use tricalcium silicate, which will reform pulpal bridges and pulpal tissue with stem cells. And those agents exist today that we're able to use. We're just not using them right now because the financial mechanisms to be reimbursed really aren't there from a Medicaid standpoint. But in private practices, they're using them all the time, especially when people are paying out of pocket. And so we have those remineralization agents, which are now using peptides or amino acids. Amino acids go into, say, a cavitated area, and that attracts things like calcium phosphorus, calcium phosphate, and hydroxyapatite into that area and forms these new crystal structures. And so we have these new agents that we've never had before. Next slide. And that's what it looks like. So this is a tricalcium silicate that's showing you the pulp, and they're awesome. If you want more information on this, if you're a little geeky like me, there's real pictures showing the stem cell proliferation using microscopic imaging, where you can see this tricalcium silicate is forming these stem cells, which are then going into odontoblasts, which then can reform tooth structure and heal the pulp. So things like direct pulp caps and indirect pulp caps, you know, when you kind of get into that nerve tissue, this can be put on top and a bridge kind of forms over top and reforms that tooth structure and keeps the nerve, the blood vessels in place. Next slide. Just because I wanted to blow your mind with my last slide, we're using nanobots. And if you have enough cash right now, you can get them used within your mouth if you would like. A big report not too long ago showing these nanobots that can help you brush your teeth, get under your gum line, and do an effective job. This one's a little more interesting because it's root canal treatments, and they can get in and find the bacteria. And yes, that picture at the bottom right is exactly what they look like. And they go in, and then you just pour them in, you put a little magnet over top of the tooth, and they come right back. And so that's kind of where things are going. These things become really interesting if you think about them in the rural environment, because they can do treatment that we usually have to send people away or to an urban area to have done. And that's it. Thank you.
Thank you so much, Sean. And I think maybe before we kind of engage in this discussion section, does anybody have any clarifying questions or anything that you want to dig into on Sean's presentation before we kind of move into that broader discussion?
I had a quick question. Moving back into the teledentistry slide that you were showing from Pennsylvania, if they're out there in the field or in alternate settings, who is doing the fluoride varnish? Is it a school nurse or an RDH or anyone, medical provider? Who is that exactly talking about that? Do you know?
So that topical fluoride varnish, the way it's being utilized is you would send the fluoride varnish to the patient. They would have that for the telehealth appointment. You would open it up and have them apply. The individual that can be on the other side of the telehealth appointment can be it has to be a registered dental hygienist. Most likely in Pennsylvania, we have the public health dental hygiene practitioner, which is a direct access hygienist. They would also be eligible, could be the dentist, could be a physician or a nurse practitioner.
Okay, so it's like synchronous, or you're either on the phone with them or on a
It has to
Zoom with
be.
them or something
Yeah,
like that.
it has
Okay.
to, yeah, it has to be synchronous. Yeah.
And is there any with the new thing that came out with the medical providers being able to apply SDF now? Are we looking at that to include that, or is that just going to fall under fluoride varnish? Any ideas?
So in Pennsylvania, it would be separate. Silver diamine fluoride is considered separate than topical fluoride varnish. And that's why you see the way that they name topical fluoride varnish specific to what it is. So silver diamine fluoride would not categorize itself as, well, it would, but people would not, sorry. People would not categorize it, at least based on where Pennsylvania is at and where Scope is at, as a fluoride varnish.
Okay.
But could that be something that comes down the line? Yes.
Okay, great. Thank you.
Anything else from Sean's presentation that folks want to dig into for Q&A? You can also add questions or comments into the chat.
Annalise, we have a question there.
I see. So Dr. Boynes, I'd like to think of a future where the patient owns their data and nobody else. What are your thoughts on blockchain as it relates to preventing data silos and warehouses being inaccessible and giving the patient control of where and when and how they wish to share their data?
I think that is where we're going. If you look at a lot of the research and even focus groups that are trying to figure out what people want from this, it's that they want to own their own data. But it's kind of interesting. It's a true bell curve of age. If you look, the older population doesn't want anything to do with it, and that will put a lot more pressure on providers who will sort of have to be able to interpret and own the data for them. And then the younger generation also feeling a little bit more protective. But when you look at Gen X and millennials, they're a little bit more willing to turn over the structure and don't see privacy within the same regard. I think what was interesting in the one analysis from Roland Berger is that, but when you get sick, you don't trust the system anymore because you are worried about being judged, or the individuals that they asked were worried about being judged. And I think that's where it gets interesting. Blockchain is going to be the way that it's going to have to work. I think where there continues to be concern is how do you keep that safe and how do you prevent people from doing a breach on your phone and then holding your health information for ransom. And I think that's holding it up currently right now. But I do think we'll get to the point where the patient will own their data and they will be able to sell it as well if they want to, or give it to others. You will go in probably to your healthcare system and make a determination if they can have full access, and then there'll be a list of how they can utilize your data. But at the end of the day, the way all the scopes work, the way HIPAA works, it really is the patient's data. It's like the patient owns their chart. That's why you're obligated to make copies of it, because they don't own the chart, but they own the information that sits in the chart. And that will always be true. But I do think there'll be people who will be willing to sell it or just give it away.
Thank you.
Yep. Good question.
Okay, I'm going to move us into our first question for discussion. And I'm going to start with Sean's response first, which is, I'll just read the question and then I'm going to stop sharing the screen so that way we can kind of just join in conversation. Folks should feel free to turn on their cameras and we'll spend a little bit of time on each of these questions. Number one is, can you share your perspective on the impacts dental technology advances have had on rural oral health outcomes over the past 10 years. And so, Sean, I'd love to hear your perspective first. And then if anybody else has responses or would like to share, please feel free.
So I think We've been able to get more mobile with our technology, which has allowed for better outreach and better resources. We're able to do more school-based care, which is um, continues to be something more common in the rural areas. Um, Admittedly, though, if you kind of take a step back and you compare a rural environment to an urban environment, especially something like interoperability, there really hasn't been much change at all. And we've continued to struggle to get that technology in place. But I think about things like going to an X-ray system that's, you know, a gun that you don't need this big operatory in order to move forward. And I think about a lot of the types of handpiece structures and kits that we now have that, you know, hygienists can put their full dental operatory in a suitcase in the back of a car. Those are huge steps forward that I think were very helpful over the last 10 years. I think where we're struggling is how we start to utilize data and then what becomes the hub and spoke with technology.
You know, Sean, if I can ask a follow-up question here, is how do you balance the cost of technology and how it really can facilitate those outcomes and expedite outcomes like you've already described, but also understanding that in rural areas, folks are already under-resourced and may not even have the basic technologies you already described, that folks struggle with broadband access and kind of that infrastructure pieces in there. So where is the balance of investing in these technologies when oftentimes we feel like we're strapped for resources of just of basic necessities at times?
So that's a great question. I don't have a great answer to it. Here's what I think I can answer it by saying, here's what we should be doing. I agree with you. It's tough to come up with the capital to invest. We tend to focus on electronic health record management or making billing easier, as opposed to making the care easier or care delivery simpler. However, I don't think from a rural advocacy standpoint that we've been effective in representing why we need to invest in the technology. And a good example is if you look at what's happening, there's big pushes for more mobile and more telehealth. But those mobile and telehealth businesses tend to be located in the urban centers, and they tend to go out to those areas or use the telehealth to communicate in. And what ends up happening is we're losing the investment in the brick and mortar or the hub that should be placed in a rural environment or a rural population center. And I think we should be able to have more resources, more subsidies, more ability, like say through the USDA, to get low interest or no interest grants because of the investment in the rural community. One dentist is about $1.3 million in economic activity. Annalise, you and I worked on a report that just came out a couple of weeks ago on workforce that mentions that one dentist in a rural environment is worth $340,000 in labor income, produces 5 direct jobs and 2.5 indirect FTE jobs. And so I think that's where we need to start advocating to get the resources in place so that we can start to see dentists who can bring 35 to 40 people to an environment or an area. And that helps to move business and economic activity forward. So I guess I would answer your very tough question that way.
I'm known for my tough questions. That was a great answer, though. Thank you. I'm curious if anybody else has experience or, you know, sharing successes about effectively using dental technology in a rural setting and maybe striking that balance between that investment and the outcomes that they may see in their patient population, or if anybody has ideas.
I have a question, Annalise. I'm gonna dovetail on what Sean was sharing about the tobacco counseling from a dental practitioner. So, Dr. Bowings, can you talk a little bit about how that could be a sustainable innovation in a rural community? utilizing, you know, the juxtaposed tobacco counseling plus the patient education for adults in a rural setting. Can you talk about the sustainability of something like that?
Yeah, so there's a couple of different parameters that seem to be that we're seeing in the early stages of this new bill. Really, when you look at the pure financial ability to be able to do it as a practice, you can delegate that structure, say, to a hygienist who these days can make anywhere between $40 and $50 an hour, and have 3 to 4 of those visits, which your income is around $100, somewhere in that neighborhood, per visit. So you're looking at $300 to $400 in revenue from a telehealth visit, versus your expenses, which are, you know, after your initial investment, are fairly low. So I think that's sort of just from that structure, it's that kind of parameter. When you're talking about tobacco cessation, we are seeing it more in the rural environment. And why I mentioned vaping, smokeless tobacco is also commonly used, as you all know, that's on this call. And so being able to structure that in a way that puts the telehealth within a rural area, a rural practice, creates a different type of spoke that can be sent out and can improve outreach. So if you look at in rural area, for example, maybe you have 4 counties around you that are also rural, and there are certain access issues. You can use this as an additional visit and additional outreach in order to facilitate that care. If you want to look at individual contracting, like a value-based contract for the rural environment, and you're able to put enough of these visits together, you can also start to think about how you're making that individual healthier by moving away from it. But it's a tough question to answer right now, outside of opinion.
Thank you.
I also posed question 2 in the chat so that folks can kind of think through that. But I wanted to, before we moved into question 2, if you'll entertain another question, Sean, about this tobacco piece that Dr. Nelson just brought up, which is, it seems like that guidance and the education piece around tobacco has, like, that's an area that technology has helped with, like with clinical decision-making tools. And that seems to be a place where we've been able to kind of make some progress, and technology has supported the educational environment. And I'm curious about if you feel like there are more ways to advance that, or a different way to advance that in a rural setting.
So I think utilizing community health workers and behavioral health in this structure as well can be beneficial, or even a warm telehealth handoff, right? So say somebody, a lot of these folks may undergo behavioral health therapy, and that's how they're utilizing, especially in a rural environment, that behavioral health structure. And so they're communicating with their therapist the same way that we're all communicating now. Could you get to a point where somebody is trying to eliminate tobacco from their lives, and or they need nutritional counseling? And can you pass that off to somebody with the experience on the oral health side, or even a community health worker who has that experience, and utilize it as sort of this holistic visit? I think that becomes interesting and really allows telehealth to be a platform of integration. And then speaking back to Dr. Nelson's question, that would uplift your financial sustainability, because you would be able to get 2 telehealth visits within one structure. And if you look at the PA bill, there's not a limitation on that. In fact, the intent behind the design was to be able to make that happen. So it's really allowing for team-based care and leadership within the rural environment, in my opinion. I'm a strong believer that there should be this mechanism in a rural setting, so that if individuals need additional assistance, need additional treatment, they don't have to go all the way multiple hours into an urban area where this is being housed. And so I think that's where the investment in those pieces come into play.
That makes a lot of sense. I know we have a question in the chat, and I just wanted to invite folks to come off of mute and ask those questions directly to Sean if you're able. So I'll pause and just see if that's desired. Jeanette.
Hi, everyone. This is Jeanette Diaz with the California Department of Developmental Services. And my question to you, or I guess anyone here, is, are there any specific rural models of care that you're aware of in any state that you believe are working really well, that would serve as, you know, possible models that can be adopted somewhere else or that are replicable? Thank you.
I'm pausing to see if anyone is out there. I would love to hear some other folks, see what their thoughts are, if there's a model that they saw that got them excited. Or if everybody's saying no, I'd like to hear that too, I suppose.
Sean, the only claim to fame that we like to talk about in South Carolina is our temporary approval for teledentistry during COVID, which has recently not been continued. So the use of telecounseling for the purpose of triaging and supporting any patient education, and then of course supporting the follow-up with establishing any in-house care that needed to be reconciled. But that seemed to work really, really well and showed some efficacy in allowing patients to establish a dental home following COVID. And a lot for some of our at-risk populations, so those that are older, some of our kids. And so now that data is currently still being analyzed, but anecdotally, it seemed to be a pretty good idea at the time for the temporary usage of that. So I'm not sure if any other states experienced, you know, a temporary policy during COVID for teleconsults or any virtual dental care triaging.
So I think, I'll jump in. There's not an ideal system. I think we're still trying to work it out effectively. Even when you look at the claims data, the amount of telehealth, teledentistry being utilized, especially outside of behavioral health, is pretty limited. To be able to take a real prevention approach to it, I think is going to take some time and a willingness to structure all of those parameters I had in my presentation together, where you're using the microbiome as a coaching mechanism. You're able to get on with a team where your medical care team, dental care team, behavioral health team are coming together around both your molecular science and your overall well-being and giving you information together as a group. I think there would be a premium for that sort of structure. Being able to use earlier predictive technologies to find things that people can do at home to prevent the decay from getting worse or the periodontal disease from getting worse, and being able to show them images of them improving, I think becomes really important. And you're mixing that in with some home health monitoring, the ability to monitor home health habits. I think that's what will most likely put it over the top, where people will be a little bit more interested in prevention. I think we're still struggling on the dental side with getting past treating signs and symptoms of active disease. And so I think the more we can tie it into making individuals' teeth whiter and straighter, and oh, by the way, healthier if you want white and straight teeth, I think that becomes a mechanism to drive it. And we're just not at that point yet. And so I think that's kind of where we're struggling. It has to improve and quickly because of the workforce situations that we have in the rural environment, especially on the dental side. I know it's affecting everyone, but we already saw a pretty significant decrease. And when you look at the numbers and the age of the dentists and dental hygienists, by the way, in rural areas, we are expecting a pretty significant number of retirements to occur over the next 6 years. And a lot of those individuals were placed by a structure called the Carnegie Commission was brought together, and they invested in increasing the amount of rural dentists in the 70s by 20%. And so a lot of those dentists that were part of that structure and that push when we started seeing a closure of dental schools in the 70s, a lot of those individuals are leaving. There really hasn't been anything set in place to replace them. And I'm an advocate of dental therapists, but even New Zealand has a dentist shortage that they're struggling to take care of folks. And they're the ones who really came up with the dental health aide or the dental therapist. And today they're having sort of those similar struggles. And so I think that's a good bellwether for us to realize we need to think about team-based care and how technology can help alleviate some of those workforce issues.
I should mention anecdotally in Oregon, there's an uptick in the use of mobile units, not as a patch solution, but as an investment from the dental care organizations and other organizations. For example, the latest one is just an example. Kaiser Permanente partnered with Medical Teams International. And what they do is they put a really high level of technology in a mobile unit, and then they travel around to rural areas in places where they couldn't possibly afford to put a clinic in place with that same technology. And so we're not there yet, but it's a way to make full use of the resources we have to overcome some of the workforce shortage, and also to share best practices between the rural communities and develop a team who really understands their rural patients. So that's a trend, at least here in Oregon.
Well, I would like to just thank everybody for this robust discussion. And very importantly, I'd like to thank you, Sean, for leading us in this discussion, giving us lots of ideas, really being that creative and innovative spirit within rural oral health. And I'm going to go ahead and wrap us up today with our remaining slides. Just a few. So number one, a reminder that November 17th is National Rural Health Day. And we would love for everybody to celebrate that together, whether that be online, sharing out information about your rural health outcomes, and just keeping oral health in that space nationally. And let me just pause really quickly. Dr. Nelson, is there anything you wanted to add to that in particular?
No, I think there's lots of state-based celebrations that are going on, and showcases and state offices of rural health. There's probably some local programs going on. I know that we have Zill from the National Rural Health Association who's on. Zill, if you have any other additional comments, I just wanted to make sure that we recognize that these roundtables have been culminating up into this close day of celebrating National Rural Health Day. All of the topics have been pinned on rural oral health outcomes, and therefore we know that the national organizations of state offices of rural health recognize November 17th, and that's something that we wanted to share as a resource and an acknowledgement for those of you in your own organization. So I wanted to just place that there just as a sentiment. And Zill, I'm going to pause just in case there's anything I may have missed from NRHA in particular.
No, I think that you got it all. The one thing that I would just also add is on like the local level celebration, there's also probably a lot of local level advocacy that's going on that day. If your state already knows sort of the composition of their state assembly or senates or gubernatorial races. So there's a lot of really great advocacy that goes on around National Rural Health Day. And so we highly encourage folks to get out and celebrate the power of rural and advocate to your legislatures, as well as having great events in your communities. So also be on the lookout. NRHA has a lot of social media that will go out that day that they're happy for you to copy and paste and share, or just, retweet or reshare elsewhere. So looking forward to yet another great Rural Health Day, everybody.
Perfect. It sounds like we have plenty of calls to action that we can engage in for that day. I appreciate the upgrades to that slide. You know what, Dr. Nelson, I'd like to actually just
Yeah.
allow you to take the reins on this one too.
Absolutely. So this is something that the National Conference of State Legislature is putting on this webinar where they are discussing lots of pillars as it relates to strengthening and supporting the oral health workforce. There will be a panel that will be sharing some particular efforts that are going on currently, the future forward, and also not omitting any of the challenges that have been occurring pre and post COVID. And so that's a part of the discussion that will happen on that panel. I wanted to make sure that everybody had access to this. Now, we know it's in December and we all like to disappear. So it will be recorded, but I did want to make sure that folks had access to this. I believe that it'll be a very unique panel and an opportunity for us to engage on the specificity of oral health. So I threw the live link into the chat as well. That'll get you to all of these details. And I believe it'll also get you to the actual link and registration for it as well.
That's perfect. And I know you'll also be sending out these slides for
I will.
folks afterwards. So you can feel free to refer to these slides. The link will be there too, in case you lose it in the chat. So no worries, you are covered. And just a plug for the Rural NRT, if you are not already a member and routinely join this learning collaborative, we would obviously love to have you. Please feel free to register. We meet monthly, and Dr. Nelson is our fearless leader, puts together a wonderful agenda. I know I personally love hearing from each and every one of you who are doing this work, and I find out something new every month. So just a quick plug to please consider joining the Open Rural NRT. And with that, I will leave one more thank you to Dr. Boynes for sharing with us today, being with us during this roundtable, and also to Dr. Nelson and her leadership. And from there, I will conclude.
Thanks so much, Annalise. Thank you so much, Dr. Boynes.
Thank you.
Thank you, everyone.
Thanks, everyone. Have a great day.